age-related changes. We all know this to be true. You've been taking care of these patients in the nursing home. They have diminished sensation. Hence, you could understand how an elderly person could literally get a burn easily, that the water was too hot. We have to be careful about those things. Situations that occur, such as patients that have developed CVAs or whatever, the trauma where it has decreased sensation. Then you have those that have diminished cognition. They are extremely at risk for skin breakdown because they don't have an understanding because of what's going on cognitive, that they are having a developed skin breakdown. They don't reposition themselves. They're sort of frozen, you know. They don't realize what's going on. I call this, you see how that discolorization, you see that? Yeah. You can actually see it on me. I am my product in my own illustrations. Vascular changes. I call that atrophic skin changes. That's what I call it. In my charting, I would say atrophic skin changes noted to the lower extremities. That's what that is vascular changes, peripheral vascular changes in the body. You're not getting as good a blood supply. Medications often affect conditions associated with skin integrity or situations that can happen. This is very important to acknowledge. The NSAIDs can mask conditions. It can hide infectious processes that are going on. We must be careful with that because too often do we want to just simply medicate. Maybe they have a fever or discomfort. We use the NSAIDs and it really masks those conditions. Y'all make sure before you sit for boards you have a very clear understanding of different kinds of herbal medications, herbal products. I'm telling you, more and more we're seeing, or we're hearing that students had these types of medications on their boards because every other corner has a health food kind of store, you see. These are over-the-counter products that our community has free hand at purchasing. It is our responsibility in terms of the RN assessment to specifically ask, what herbal products do you use? Because those could interfere with other medications that they may be on. Might be even contraindicated for certain prescribed medications. Moisture on the skin. Exposure to moisture leads to maceration, softening of the skin. And you guys have already been taking care of patients. Maybe you have seen some of these areas of skin breakdown, these folds you see. I myself may, as I get older, have that opportunity. One of y'all is going to take care of me one day, and you're actually going to see Miss Moore with some evidence of skin breakdown because of those dark crevices, right, the folds of the skin. This, you know, and I was trying to find a good picture of it, but I couldn't. This is the best I could find. It's like a heel of a person that's just, see how it's soft? I mean, you can envision that. For some reason, I don't know, the moisture. See, you can picture that if I touch that, that's very soft, right? Squishy, soft. Just imagine, but more things associated with this moisture in the folds, underneath the breast, in the theory area, at the femorals, these areas where we start getting extra humps. Yeah, y'all know what I'm talking about, right? Those areas are often overlooked because why we're in too big of a hurry to evaluate. And I say again and again, you guys get that technique of assessing these things. Think of what can go wrong with your patient. Evaluate those, get them corrected. Be proactive in the way that you take care of your patients. You want to ward off things that can go wrong or correct them. Those things could be simply taken care of before they go into a septic kind of shock condition if we'll just simply take care of it early on. Fever. Fever sometimes can lead to conditions where they break the fever, they get diaphoretic, and what do we not do? We don't do good hygiene with our patient. We leave them set in their diaphoretic state. You see, y'all can imagine that, right? You see what I'm saying? Because we weren't on top of that, we didn't delegate, tell our, maybe our CNA, could you do a tepid bath for Mr. Jones or Mr. Moore or whatever. You delegate. Learn to delegate things. If they have, or if you have to do it, you do it. Because that can also lead to conditions of skin breakdown, maceration. Yes, I tried to find the most hideous infection, didn't I? Yeah. I did the best I could. You did pretty good and good. I thought y'all enjoyed it. I think that green background helps a lot too. It's very colorful. Yeah, it looks like this person has had some IMD, had the plastic surgeon and vascular surgeon come in to try to save that foot. You can already see, and we talked about the atrophic skin change. Can't you see? I don't think that would be considered, this person's been out in the sun. You see what I mean? This person has some atrophic skin changes, which is vascular. This foot just doesn't happen to have the damage that this one, but he has, in both cases, he does have atrophic skin changes. Yes?
And that left foot on the toes, is that cyanosis, or what is that?
I think it is, no, on the left side, I think it was just the way the picture was taken. One would hope. Look at the nails, how thick and yellow. Y'all seen some of this, haven't you? Yes, already. We had a podiatrist that was there at our facility week before last, didn't we? Yeah. I don't know, it might have been a PA podiatrist or a nurse practitioner, I don't know, or he could have been a doctor. I didn't ask him his his degree qualifications, but just so you know, they do have podiatrists that come into nursing home facilities. I told you, you have a patient come in, that's your responsibility as RN, tell that primary doctor, this person needs to be seen, a consult with a podiatrist needs to be coming in. And they don't mind writing that because that's legitimate. Somebody that's diabetic, this person probably is a diabetic, most likely. But see, you can just look at that and say, man, what the infection, right? This person's septic. This person has a great chance of not having success here. Hence, what can happen? Amputation, yes. He's heading that way. You can see that, can't you?
Would they do it just up to the infected area or just take that whole
They
foot?
try to take as little as possible. They try to take as little as possible, but unfortunately, this looks to be like it could eventually be right here. Hate to say it. Yeah. Bad. Looks really, really bad. Yeah, could have been. I just tried to find the best depiction of what infection like. So you always have that picture in had. So again, you get a patient newly admitted, you be very, very careful with your assessments, because I will tell you, person, insurance, we gotta always think of how to protect the patient and your hospital that you work for. If they come in and you don't pick up on decubitus, and then all of a sudden this thing erupts into something really bad, because you didn't on your initial assessment catch it, and it was there. It really was there. The Medicare will not fund the payment. And let me tell you, this millions of billions of dollar business, these to treat decubitus ulcers. It's money. It's expensive across the nation. Statistics, if you looked up the statistics of cost across America, of what it costs as a nation for decubitus. Lifestyle, tanning, hygiene habits. We have poor hygiene habits that can lead to skin breakdown. Regular exercise, and I have to say, I hate to say it, but I was too tired yesterday to do my weekly tennis. I won the ticket. I had to work on these cards, see. I got done with my clinical. I said, no, I gotta fix these cards up. So I opted out of my tennis yesterday. I shouldn't have done that, should I? But I did. For the good of the body here. Your body's not mine. Smoking significantly, and that's where you'll see on state boards, smoking cessation, treatments, patient education, smoking cessation. That's always an answer to select. Body piercings and tattoos. Well, we're seeing that more and more. We have nursing students come in, they have tongue piercings. That's going to be an interesting experience come 50 years from now. You guys are nursing home patients. You'll have these body piercings. I mean, that, I'm just saying, strange tattoos.
Hey, at least you can take a piercing out.
Huh?
Tattoos are permanent. Just to say that.
Do what now?
Tattoos are permanent. Piercings can be removed.
Yes. Well, you can remove them tattoos, but it costs a pretty penny. They're expensive. Don't forget, going back to that, I forgot to mention about the vitamin C is very important. Y'all are having a test on vitamins today, right? Mm-hmm. There you go. That might help you in your pharmacology. I don't know. See, I'm trying to help you. Going across there, you say, yes, Dr. Moore includes pharmacology in her fundamentals class. There you go. Then we had talked about types of wounds. We have an open versus closed wound. Closed wound would be there's no breaks in the skin. You have bruising, sprain your ankle, but it's, no skin break within the breakage. But then you have those the open wounds, lacerations, abrasions, puncture wounds, surgical incisions. An open wound. An open wound has more scar tissue than a closed wound. If they close it up, totally close it. But if they have a situation where they got to leave it open because they have a concern that this patient, if they totally close it, they have a concern that that patient will develop a septic condition, so they have to leave it open and let it heal from the inside out. Those are the ones that you will see more scar tissue from. Acute wounds, short duration, that makes sense, right? I don't think that on state boards that they'll necessarily ask this type of specifics, but it's possible they could. It's always possible. Chronic wounds are those that are going to be, there's a chronicity, and it might be based on a person's health condition, a chronic health condition. They've got they've got problems with their peripheral vascular states that would in turn result in some potentiality of developing these pressure ulcers, arterial ulcers, or venous stasis ulcers, chronic states. Acute would be, I cut my finger when I was peeling potatoes or something with that sharp knife I bought at the on Food Network line, right? I don't know. Or paper cuts, you know, that's cute, but they do hurt, don't they? They do hurt. There's a nice little illustration, and I just pulled this off the internet. Your book might have a different kind of verbiage, but in all cases, it's addressing the concept of the acute and middle stages, and then that recovery stage, and what happens. You see, that's all I was trying to, because every book will be a little bit different anyway, but it's still the same kind of concepts. Depth of wounds. You have different types. Superficial. Friction, shearing, or burning. We have caused a superficial wound because we were not careful in how we pulled our patients up in bed and we did shearing. That's an example. Partial thickness. Now this is interesting, and I want you to remember this. So a patient that has a wound that extends through the epidermis into the dermis would still be classified as a partial thickness because the wound did not extend completely through the dermis layer. Why do I take the time to read that? Because you might see that on your exam next week. Hint, hint. All right. There you go. Full thickness wounds, they extend into subcutaneous tissue and beyond. The deeper the wound, it's just common sense, the longer it takes to heal. You have different things in terms of regenerative epithelia healing. You have primary intention healing. You have secondary intention healing. And you have tertiary intentional healing. So in your textbook, it does address these different types of healing. I went in on that particular slide to give you a little more detailed information, explanation about these different types of healing processes. I wanted to give you pictures. I don't think I could find all pictures, but I found some illustrations that speak to these different types of methodologies of healing, the constructs of how things heal. Stages of wound healing. Again, remember that about 5 slides back I found one on the internet. This I sort of created. I think I created this one. I did, and it's from your book. So you have the injury to tissue, the inflammatory process. It can go one or two ways. You can stabilize, or it has inflammation. So you go, and the hemostasis and the inflammatory effort, it does occur at the same time in that acute stage. You have the contraction of the clot and the migration of the white blood cells to that, what they call that prolific stage or phase. And then you develop the maturation phase. That's where it starts shrinking. Anyone ever have a surgical wound?
No,
I have. And when I did this, I said, you know, that's exactly what happened to me with my, where I had appendicitis. And they had to do exploratory surgery. At the same time, I was 6 weeks from delivery. Yeah. Took a long time for that site to heal. And then I had horrific scarring tissue, so pretty ugly scar. wound closures, and you guys have seen these in the skills lab. And maybe they're in your nursing home, when you're on the wounds, you see those theory strips, right? You've seen sutures, you saw them on that foot, right? Going back to the infected foot, right? Surgical staples, you guys had the opportunity in your skills lab to remove staples. You'll see that most likely when you're going into the hospital and you're on the med surg floor where they've done the surgeries. And they tell you, take out every other staple. The doctor will order that, or every third staple, whatever. Surgical glue, now I have not, to be honest, seen that on the floor, to be honest. Negative pressure wound therapy. Surgical debridement. Always fun to work with a plastic surgeon on doing debridement. Not, let me tell you, some of the things that you see happen, you grow as you're tough in your stomach, right? It's pretty intense. And then they have some of these centers, these wound care centers, they have this hyperbaric oxygenated therapy. They actually will have patients come and they'll just be inside the chamber getting high percentages of oxygen. And this is actually a picture that I found of before and after of being in a hyperbaric. So you can see how that chamber actually helped that guy a lot. That's significant. Huh?
What would that be? Would that be like MRSA, or what would that
It possibly, you know, I don't even know. I found it on the, it's hard to say what happened to this person. It's hard to know. I just found it on the internet. They didn't have any description of what it was, the scenario. But, you know, you could have, surely it could be a situation with somebody with a MRSA growth. Because it's very hard to combat those conditions sometimes. Types of wound drainage. Some of you guys may have seen some of this, but let's talk about it. Serous exudate, sort of a watery red, little cellular matter. Sanguinous, deep, it's that bloody, it's just a bloody kind of drainage. You get a patient back from the OR and they have JP drains. Initial assessment, it's sanguinous. It's just blood. It's just blood. Serous sanguinous might occur after 24 hours. You start seeing where it's mixing. The serous and the sanguinous. It's starting to have normal properties. Now, I will tell you, purulent is not normal. Purulent is, it's, you know, and I tried to see, I gave the worst picture I could find. That has the color of purulent, doesn't it? We all concur, don't we? If it's a purulent sanguinous, it'll be a red tinged kind of pus. I couldn't find that one really on the internet, but this one, you can see that's just, that looks bad. I have no idea what that is, and I don't want to know. The image is just purulent. Complications of wound healing, hemorrhage. Hemorrhage occurs within the first 24 to 48 hours. Internal bleeding you won't necessarily see sometimes. They'll have in the pelvic cavities. It can be well hidden. Well hidden. But what you'll see is you might start seeing altered vital signs. A hematoma might result. Hematoma. This is a person's leg. I believe that's see the back end of the hematoma. Patients that go for a heart catheterization, And they tell the nurse to, once that ACT result is, and that's related to bleeding times, is low enough, you DC the sheet. And it's pretty big diameter into the artery. But if you are a nurse that does not have good skills in DCing sheaths, you shouldn't do it. If you don't feel competent doing it, and you know, you might have been checked off and certified that you can, but you know, I've seen some bad situations where they've just not done a very good, consistent pressure, resulting in what they call pseudoaneurysm, and it's their technique of how they held that pressure that caused the internal kind of bleed within the area. This could be that, I will tell you. That, you know, like I said, when I find illustrations, it doesn't give this scenario. And that would then require that the patient might have to go back to surgery. Things like that happen. External bleeding is, of course, obvious. It's easy to recognize. You see it. There's no question. That's bleeding. External bleeding. Obvious. Infection. Again, I tried to find a good one. I don't know why it is I like the deep, but I think I'm trying to remind y'all the concern that we must be with our patients that are diabetic, teaching good foot care. Right? You suspect infection if the wounds fail to heal, their localized swelling, redness, heat, pain, fever, foul smelling, purulent drainage. Common sense, right? Just common sense. Another complication, dehiscence. Rupture, separation from one or more of the layers. I don't know what this is.
I was
I
just
don't know
about to
what kind
ask
of
that.
surgery.
Where is that at?
I'm not sure. But I want you to imagine, if you see this, see these are sutures.
Who does the stomach? They go to neighbor right there.
It looks like that's a colostomy or an ileostomy or some sort of ostomy, doesn't it?
That's the navel, right?
Something.
You can see the neighbor.
But this may be as a hip, a side position, or I'm not sure.
Look, don't they look like the neighbor right there in the middle? Look with a little curve
Yeah.
right there where the indents over
It could
any.
be. It could be. Whatever it is. The issue, my concept here, you see these are sutures, aren't they? Y'all see those surgical sutures?
Mm-hmm.
This person had surgical sutures, and they've either eroded or broke, you see, because maybe what's happened is this person's gotten excessive fluid.
Mm-hmm.
You know, it looks like a gut, you know, to me.
Mm-hmm.
Dehiscence. It's like a pop. You can imagine, oh yeah, I felt a pop. These suture lines breaking away, right? Keep them on bed rest. Keep the knees, because see, it takes less pressure off if it's abdominal. You see what I'm saying? Physician needs to be notified, and you must brace yourself for evisceration potential. Evisceration. That's total separation. It's rare, but it's a surgical emergency. You want to cover those organs that have protruded out through the wound with sterile normal saline solution. You keep them on bed rest with the knees bent, and that you notify the surgeon, the house officer, and OR. This is going to have to be something that has to get immediately taken to surgery.
Total volume of liquid.
There's an example of an evisceration. See how it's protruding out? Something with the intestines there going on. Fistulas. Fistulas, abnormal passage connecting two body cavities. This is the one that you'll see a lot with females.